Yeah, hi, Dr. Vikram.
So, good evening, everybody, and welcome to this another episode of Wound Management Series. We have today with us Dr. Warid Altaf, who will be speaking on VAC therapy in open wounds. We also have with us our panelist, Dr. Kaustubh Shende, who is a plastic surgeon at Sancheti Hospital. We also have Dr. Ajinkya, Dr. Viraj Tambekar from Mumbai Hospital, Mumbai, and Dr. Vikram Wag with us. So, over to you, Warid, to start the proceedings.
Yeah, thank you, Dr. Ashok, and thank you, OrthoTV, once again for giving this opportunity. So, we are having this series on wound management, which has probably not been covered so far. All of us know that it's a big problem if we land up with some infected orthopedic procedures, and to deal with them is always has been a challenge. So we'll try to cover some part of it today by covering the VAC therapy in the wounds related to the orthopedics. So I'll try to keep it more case based so that we can come out with some discussion later on in by the end of this talk. So the mainstay of a non-healing or a chronic wound is meticulous debridement of all necrotic, devitalized, and fibrous tissue, with a primary goal to obtain healing and ultimately a closure of the wound. So that is the basic thing we all know. So this negative pressure wound therapy definitely has revolutionized the current wound management. Its use has been drastically increased in, I think, last maybe a couple of years, and it has a very wide indications to say for that matter. So it's used in acute as well as chronic and as well as non-healing wounds. So there's a lot of literature. If we go through literature, you can see that you'll find a lot of literature uh, regarding this VAC therapy for in orthopedic surgery or plastic surgery, maybe after infected internal fixations, after fractures, or after total knee and hip arthroplasties, after spinal fixations, or any other orthopedic surgery. So it has been proven and time tested now that it gives pretty good results in all of these situations. So coming on to the fractures, the compound fractures along with the extensive soft tissue loss is always a challenge for an orthopedic surgeon. The patient has to go multiple surgeries, plastic procedures, and cost is also always an issue. The aim is to cover the exposed bone and also definitely to achieve the union. So it's always a challenging whenever there we see a compound fracture. It's always a challenge to treat, because ultimately you have to achieve a union of the bone as well as a good cover to that as well. So I want to make this statement that a VAC therapy is not an alternative for debridement. Definitely not. Whenever we are seeing some kind of an infection, that needs to be debrided, and not just directly a VAC therapy or something like that. So just in brief, the mechanism how it works, I think most of us know about this. There are two mechanisms, that is a macro strain and a micro strain. In brief, I can tell you about this is a macro strain works something like this. So when you put a foam in the wound and then a negative pressure is applied, and then you can get the edges of the wounds can be drawn closer, so it reduces the size of the wound uh, in that way. So in brief, the indications are acute wounds like traumatic burns, flaps, grafts, subacute dehisced wounds, diabetic ulcers, pressure ulcers, and venous insufficiency ulcers. So a lot of wide spectrum of indications. So I'll come to cases. So this is a 35-year-old male had a road traffic accident, had a chest and abdominal trauma, and a major degloving injury with a shattered femur. So this patient was initially stabilized at like a damage control orthopedics. We did an external fixator, a, and then a VAC therapy was applied. A VAC dressing was applied, And this was after first session of first dressing, and then it was immediately covered with a split skin grafting. It's always good to cover the wounds as early as possible, debride it radically, get rid of every suspicious infected necrotic tissue, and then cover it straight away with a split graft or a flap. And this was the 10th day, and this patient had a decent range of motion, and this was converted into a internal fixation. So that's how the fracture, it was a compound fracture, and then later on the X fix was converted into a retrograde interlocking nail, and his range was around 90 degrees or so. So that was the 2 years follow up. So many a times we come across situations something like this. TA rupture is a very common injury, maybe a degenerative rupture or a traumatic rupture. We see this infection many a times in our practice, especially with the degenerative tears, which have been reconstructed, some kind of an augmentation or some repair, direct repair has been done, especially with the non-absorbable sutures, which have that tendency of having some reaction and then subsequently developing infection, especially in diabetics or immunocompromised. So this was a 60-year-old female. She had a TA rupture and was operated 10 months back, and it was a very bad, foul-smelling discharge from that wound. So you can see those, that is a, it's a bond sutures. And we got an MRI done which showed multiple kind of an abscesses coming out from within the surface of the tendo actually. So we did a debridement. Fortunately, the integrity of the tendon was there. It was not completely lacerated. So we did a thorough debridement, and then a vac was applied because it was very badly draining. So doing simultaneously doing some kind of a flap or a graft or something would have been maybe disastrous at that point of time. So a vac was applied, and this was after a week or so. So at this point of time, this looked settled, and then waiting after for a few more days, and a faciocutaneous flap was done to cover that uh, tendon. And that was, I think, yeah, that is the 6 months follow up. It was very well settled, and the infection had settled down. So I'm not saying that the vac is definitely to be put on in all these situations, but I think it definitely helps, especially when there are draining wounds and you are not sure about whether to do a plastic surgery like a flap cover or a skin grafting right away. And whenever there's a doubt and you may think that we need to wait, a vac is a good option in those situations. So this is a 40-year-old male, a runover injury. You can see this. This is a circumferential kind of a degloving injury, and we know in such situations this whole circumferential skin will go along with the subcutaneous tissue deep down till the muscle. So this patient, these were the X-rays of this patient. So he had a very bad injury in the elbow. It's like a side sweep injury, distal humerus fracture with pretty displaced medial condyle fragment. So the problems here where it's we call it a side sweep injury, an intraarticular fracture, distal humerus with some bone loss, gross ligamentous instability of the elbow joint, degloving injury to the arm, and he had an head injury as well. So all these things were there. So this is what happens when you do the first debridement. So you remove all the suspicious, whatever dead skin and subcutaneous tissue you know which is degloved, which is not going to survive, and then this is how the bony fixation was achieved with multiple K wires. The suture anchor was fixed into the medial epicondyle to get back the medial flexor pronator origin along with the medial collateral ligament to get some stability. And you can see that tubing of the vac. So a vac was applied at on that day. So this is what was done. This is subsequently second dressing after the vac, and it was a reasonably good looking granulation tissue. The muscles were covered and the nerves were not exposed, fortunately. And then this was covered with a skin grafting, and this is how it looked at 3 months. Pretty much stable in place, and that is at 6 months when we had we had planned to do an arthrolysis to improve the range of motion. So that this video was just before that. So we could manage to get maybe somewhere around 90 degree, uh, 30 to 90 degree of range. And that particular day he was posted for removal of those K wires and arthrolysis of the elbow joint to achieve maybe some more degree of flexion, which he wanted. So that is how we proceeded. So this is another case, is a 20-year-old female, again a runover injury, a four-wheeler runover injury. She had some ligamentous injury in the knee joint, but no fracture. Again, we know that this whole thing is going to go, and then this is how it looked after debridement. This is a side, this front and back view. The problem here is that it is right over the knee joint, and the biggest trouble of having these wounds is a stiff knee and an unstable knee sometimes if the collateral ligaments are gone. So this particular girl, again, we had put her on a vac dressing, and after the second vac dressing, done a split skin graft, and that is that is at 4 months she did pretty well. She had a stable joint, walking all around, cosmetically not very happy though, but then she got a good function, good range of motion of the knee joint, and a good stability. Her ligaments, intra-articular ligaments were intact fortunately, and she that is how she was at 4 months, doing active SLR, pretty much stable, walking. 40 Another case is a 40-year-old male, had a known diabetic for a long time, established diabetic neuropathy, comes to you with something like this, which with a fluctuant swelling around the ankle joint, fever, toxic, and you know that this whole thing is infected. So he was an uncontrolled diabetic, HbA1c of 12 gram, chronic smoker, sedentary lifestyle, and established neuropathy on EMG and NCV studies. So we took him for debridement, and the moment the skin incision was taken, and this was the condition of the this thing, the pus was flowing, and then after doing a meticulous debridement, the he was put on a vac therapy, and we could see some good granulation tissue. The fibula was fortunately covered, and then after a couple of more vac dressings, this was converted into, we had done a split skin grafting, and then that healed pretty well. We come across these situations pretty often. This was a 45-year-old male, a 3 weeks old post surgery for the distal radius fixation. So this was done somewhere else, and the patient had come with this sort of wound, which is draining pus from the forearm, and this kind of an internal fixation has been done. And just at 3 weeks, if there is a gross infection, something like this, it's a big trouble. So now you have to think a lot in planning. Like, obviously we have to go down there, clear everything, do the debridement. So removing an implant is again a problem, because at 3 weeks you don't expect any union to happen. So if you're removing your implant, then you have to stabilize it with some sort of an external fixator, maybe internal fixation by K wires, and then span it and do an external fixator. And so 3 weeks is too early to remove all the implants. So we did a radical debridement, went down, and there were two plates applied on the radius, one on the volar side and one is on the radial border. So probably maybe extra dissection while doing such kind of surgeries does lead to handling of these muscles and maybe some infection. That is one of the reasons to have infection in closed fractures. And we just we did remove one plate, which is the lateral plate, because the screws were already loose at 3 weeks of time. There was a dead piece of bone which could be identified, and which was already separated from that parent bone. And then this particular patient was put on a vac, and expecting to settle, because counsel and very well counseled before that he may need removal of this particular implant also, and may have to be put into an external fixator, or some K wires for internal fixation to maintain the alignment. So taking that chance of keeping one implant inside and doing a thorough debridement, because it was just a 3 weeks old injury. So that we went ahead with that, and fortunately we got some response, and this started to settle. We had just done a loose closure and then put a vac on that, and expecting it some granulation tissue to form, and then maybe quickly cover it with a split skin grafting. And then this particular patient settled pretty well, and this was, I think, down the line 3 to 4 months. His fracture had healed. He had some problem with his tonus supination, but then his wound was healed. And then in this situation, we can go ahead, do any kind of an osteotomy if he wants some better range of motion. But then this particular part, that infection thing had settled. So I think doing why I put up this case is doing, and if you see some picture like this at 3 weeks time, doing a radical debridement is very, very important. Just sitting on it, giving antibiotics, and waiting for something to happen is does very rarely happen, and that screws up the whole internal fixation which has been done earlier. So going in at the right time and just debriding radically is does help and gives good results. So this pretty much this is looking like it's like a scary wound right on the anterior surface of the knee joint. So like looking at it, we are always concerned about the fate of the knee joint. If you see some wound like this, a patient coming to your clinic with a wound like this, and you are always afraid of this infection going down into the knee joint, causing septic arthritis or stiffness of the knee, and so on and so forth. So many complications can happen. So this particular patient, we just did a good debridement and put a vac, and you can see how nicely this cavity has filled up, granulated inside. And the advantage of putting a vac in such situations is that you can even mobilize the knee joints gradually, along with having a dressing on. And this was again after uh, two more vacs, and this almost was ready for skin grafting. So we were even not expecting that we'll get a good result in maybe 2 to 3 weeks time. And otherwise we were planning for some big free flap or some kind of a thing, and but then we it settled, and when this was grafted on later on. So early mobilization, knee range of motion, weight bearing, so pretty much taking into consideration, and all this thing was done. So this is another case of a 25-year-old male, a crush injury, has a shattered elbow joint, very bad contamination. You can see the condition of the muscles, major muscle loss, and a posterior interosseous nerve was completely lacerated. So this is the fracture. You can see that that is a medial epicondyle which is flying off completely. An ulna is shattered. This is what we call as the transolecranon fracture dislocation. And the bad part was it was very grossly compound and open fracture. So this was the condition of the common extensors, and this was debrided thoroughly, and a vac therapy and a split skin grafting was done. An external fixation was done, and internal fixation was done with multiple anchor sutures and K-wires. And that is I think at 4 to 5 months we got a decent range of motion. Probably we have noticed that all these we do a lot of these side sweep injuries in which there are bad transolecranon fracture dislocations which are compound most of the time. So initial thorough debridement, stabilization with an external fixator is the key, and if that is done properly, they end up having a good result. In this particular case, we had done a primary repair of the posterior interosseous nerve, right, just at the radial neck level, and we could get a good result in this. He has a good thumb extension, a good finger extension, and so. Later on, if he has a good stable joint, he is a very good candidate for an arthrolysis of the elbow joint. If he at times wants more range of motion, maybe a better range of motion, that can be done. So this is another case is a 70 years old male, a crush injury, diabetic lower third tibia fracture. They are always, you can see this bone is jetting out from the skin here, and this is a very bad kind of an injury here. A lower third fracture, very high chances of going into non-union because of the precarious blood supply it has. And diabetics, of course, they even have bigger problems with wound healing. So this particular case, this is a fracture. that this is a bone which was jetting out from the lower part of this wound. And this particular patient was again an external fixator and an internal fixation with intramedullary wire in the nail in the fibula was done. And you can see this part of an edge. We had a doubt about this part of, maybe because we had sutured this flap back, which was avulsed kind of in the initial part of the injury, and then that was a necrosis, marginal necrosis of that happening. And that was again debrided, and then a split skin grafting was done over this. So this is, I think, 4 to 5 months. We got a very good result with this. The tibia fracture is completely healed. The fibula nail is in situ. Sometimes, luckily, you can get in union by external fixators if the alignment is properly maintained. And once we start weight bearing, gradual weight bearing with the walkers, you tend to enhance that healing. And in this particular patient, you can see at 4 months he's walking full weight bearing. He has a very good range of motion in the both his knees and ankle. And that's how we could achieve union in this case. So this is another 10-year-old boy. Crush foot injuries, again, we commonly do see. So initially just stabilize it with external fixators, and then this particular patient, a vac therapy was applied, skin grafting, and that healed pretty well. So this is a 45-year-old male. It was a blast injury 2 months back, but somehow this wound was not healing. A skin grafting was done, although it was a superficial wound. But then a skin grafting was earlier done, which was completely not taken up. And then we did a debridement, curated it off, and put a vac, and we could see a good granulation tissue, because this particular image, it looks a very pale kind of a granulation tissue. And then this we could get this good granulation tissue, and that was immediately skin grafting was done. At 3 weeks we could get a good result in that. This is a 50 years old male in a heel pad avulsion with infection. Again, diabetic patients. Diabetes is a big problem. Debridement, external fixator, and a vac. And you can see that, seeing again a good granulation tissue and immediately covered with vac. So we have been using this vac. Maybe most of the times we put it over the skin grafts when the graft is maybe on surfaces somewhere around the ankle or in the axilla, where it's kind of an uneven surface. So you can put it over the skin graft, and it is proven to have good results. The take of the graft is better. So that is how it healed. So this is another case, a 45-year-old male, a traumatic near total amputation of the ankle. So this particular patient, we had to do a vascular repair, tendon repair, nerve, everything was gone. It was almost a total amputation, and external fixator. So that is how it looked. And then after repairing everything, a vac was put over that. Even in this case, a vascular repair was done, but we had put a vac with a very low pressure, and we got a good, you can see a good granulation tissue. Then a split skin grafting was done, and that is at around 3 to 4 months. This patient, he had some extensive weakness. There was some kind of a foot drop, which was a very weak dorsiflexion, and but he could manage full weight bearing, and he was on the rehab for strengthening his dorsiflexors of the ankle. So 65 years old male, another case, an uncontrolled diabetic. And this is a shattered tibia. You can see multiple fragments, maybe some amount of bone loss, and this was a biplanar kind of a fixator was put, and a split skin grafting was done, and a vac therapy along with that. And this is that video of that patient. So this is a 20-year-old male, open fracture dislocation of the ankle. He was a sports player, unfortunately, but he had a very bad injury, and this we had put him on this vac therapy after debridement, and then skin grafting was done. This is again a 38-year-old. A hip disarticulation was done for an infected fracture neck of femur. This particular patient had a neck of femur fracture. So this is what you're seeing is an stump of the hip disarticulation. So he had an infected hip screw fixation, which was infected, and for that, all those multiple surgeries had to be done somewhere, and ultimately he had landed up in an hip disarticulation. So you can see the fate of an infection, how bad it goes sometimes. And then with this particular picture, he had come to us with a non-healing stump of an hip disarticulation. And I think that we found him an ideal candidate for a VAC therapy. We just keep on putting VAC till the wound contracted, and we could find some sort of a relief there. 45 years old male, again uncontrolled diabetic non-healing wound. So this is the lateral side, and this is the medial side of the wound. You can see on both sides of the wound there is the both sides of the ankle. There's a wound like a circumferential kind of a wound. So again, we had done a radical debridement, then a VAC therapy, and skin grafting. So this is a 30-year-old male. He had an infected non-union of the tibia. You can see the dead bone which is jetting out is probably a sequestrum. It is there, and multiple surgeries had been done to achieve union to cover this part of the bone, but this was not stopping. Somehow he had developed osteomyelitis, and this was an internal fixation which was done. So we decided to maintain this internal fixation, and excise this dead bone, put a cement spacer, what we call is as masculate technique, and a cement impregnated antibiotic beads, and that was covered with a cross leg flap, because probably that was the only option for this particular patient, because his entire leg was injured, and doing a free flap was also a big challenge. So a cross leg flap was done, and this was 3 weeks post. Yeah, this is post separation settled, and then that cement spacer was removed at this particular time, that division, and then subsequently this patient went for Elizaro ring fixation. So the take-home message is that VAC is an effective, safe, and patient-satisfactory modality treatment. The patient can be put on a therapy on a day-care basis and a home treatment within appropriate antibiotics. It has tremendously reduced the need of flap surgeries, and most of the times skin grafting is sufficient, which has been studied in some recent literature, and it reduces the number of resurgeries, hospital stays, more morbidity, and overall cost of the patient. But again, I want to say that it is not a replacement for any debridement, or not a replacement for any flap surgery for that matter, which needs to be done in some patients, and they can be randomly put on VAC therapy. Thank you very much.
Of the treating practitioner, what and where that person is trained, what their approach to a case is. So I don't think it's reduced that at all. What it has definitely done for us, it's given us a bit of a, I would say, a lifeboat. It's given us a way to give it some time to think as to what you want to do. Very often when you're presented with a very complicated case, bad crushed fractures, this, that, and the other, and you're not quite sure what will live, what will not live, this is a good lifeboat that kind of keeps the place clean, relatively hygienic environment, which gives you a time to sit back, maybe refer to some books, talk to other colleagues as to what to do in a complicated situation, and then come back with a definitive answer for cover. So this is as far as, replacing flap surgeries or whatever. The second comment I'd like to make is about what else is new. I have been reading some papers recently where they are actually applying VAC to wound edges where flaps are looking like there could be some venous congestion, they could be dying with venous congestion. Right. So it's applied onto the flap, onto the borders of the flap, and they've found that because of that negative suction pressure, the venous congestion is reduced and flap survival is enhanced. That's one thing. The second thing they found is that in microvascular flaps especially, again, where you're not very sure about your anastomosis, early on, if you pick it up and you apply it on the edges of the wound, things are improving. So that is the newer advancement beyond cleanse foam. They're, of course, now experimenting in animal studies in terms of how much pressure to apply and things. But I guess for an orthopedic kind of a presentation, that doesn't really hold too much interest, at least for this particular viewership.
Yeah. Right. But definitely, I completely agree with what you said, that it helps us in buys time, and by that time we can have that sterile environment in the wound, and we are at least some tension free, that okay, we can plan for that particular complicated case. That is absolutely right.
Yeah, one thing I was like asking.
Yeah.
What is your experience about using a VAC on after doing a skin grafting? Like that is the new trend or the new literature which is saying that there is lot of case series which are going on
Correct.
with vac on application after the skin grafting. That is also a new trend.
Yeah, my personal, I think Viraj will comment later on. My personal experience is that I've not read honestly a lot of literature about this, but then my personal experience is that it does make a difference. It does make a difference, especially on the wounds, maybe it's on the back of the knee, in somewhere in the axilla, around the ankle, when we have grafted, and that dressing is always a problem. And I have seen my personal opinion is that it takes up pretty well in such situations, and maybe the percentage, if we calculate it by percentage wise, then it definitely will show some increase in the take if a vac is applied over the skin grafting. So I've been practicing it very regularly now. Maybe 7 out of 10 skin grafts I put a vac on that, and be sure that I think it takes up pretty well. I don't know, Dr. Viraj can comment more on that.
I would agree with what Dr. Warid said. However, in my practice, very often we have a lot of patients who can't afford it.
Yeah,
So, when you look at a basic dressing that you do for a skin graft recipient site, the cost of the dressing is not too much. It's usually some paraffin impregnated gauze, maybe
right.
some povidone iodine, cotton, and some other gauze, and a Gamgee roll, and probably a plaster slab or something like that. Now, that doesn't cost too much money as compared to a vac dressing, which will cost them a minimum of 10,000 rupees at least, if nothing else. So if you're looking at cost factor, then of course it's not the right thing to use for patients. But if you're talking technically in terms of graft take, I think the negative pressure wound therapy is a brilliant idea. The only thing that I do here is that when I use negative pressure wound therapy for graft dressings, I make sure that the interface that I use, instead of Bactigra or something like that, I use either Adaptic or I use Mepitel, which are non-adhesive interfaces. So what happens is when you pick up that non-adhesive interface, which is either a Mepitel or a Adaptic, if the graft doesn't come along with it, so even if some of it is not taken, it still remains there. And then a subsequent dressing, you can actually salvage that graft. That's the only additional point, if at all, I'd like to make.
Okay. Yeah. Agreed. Yeah. Any other question, Dr. Vikram, Dr. Kaustubh?
Yeah, I think that was, I would just carry the point Viraj sir was saying. The cost effectiveness that we have to see on every patient to patient or case to case basis, we need to see that, because in Indian scenario, most of the times the patients which we come across are usually road traffic accidents. Those are usually pylon riders, or those are in the farmers. Most of the time they are not affording, and it becomes very difficult. But then again, we will have to do a comparative study, like whether using the vac reduces the cost of surgery and the hospital stay, and how much will be the total expenditure compared to the surgery versus the vac. That we will have to do a study in Indian scenario.
Agreed. Yeah. Yeah.
May
Agreed.
I comment there, a small one?
Yeah.
Yes, yes.
So there have been extensive studies that have been done in the West as far as cost reduction is concerned. The amount of time that the patient stays in the hospital, the antibiotic therapy and the cost of the antibiotics per se, especially higher antibiotics, and then the number of repeated surgeries, repeated debridements, etc., in a hospital. So in a Western scenario, developed West, America, UK, Europe, etc., it is unequivocally proved that NWPT has saved costs to patients. It saved labor-intensive care, it saved costs, all of that. So it's a great advantage, no doubt. In the Indian scenario, also, I believe that it will save costs. May not be as much as it will do in the West, but it will definitely save costs. 100%. I'm quite certain about that. If proper data is gathered, and if we have like a registry of what we are doing, etc., which unfortunately in our country we don't have registries for anything. But if
Yeah.
we do have, I'm sure you'll find that there is cost effectiveness.
Definitely. Definitely. I have one question for Dr. Viraj. That what is the duration of your one vac dressing? Like, is it fixed, or it's variable according to the wound, or
Thank
because
you.
what they recommend is 2 to
Thanks for
3 days.
asking that question.
Yeah.
The reason why I didn't bring it up on my own was because it might poke fingers at some people and they may not like it.
Right.
But so the thing is, I normally keep my vac dressings for about 3 or 4 days and I change them every fourth day. I know of a lot of people who keep them up to 7 days, 8 days also. Because I get patients eventually referred to me where VAC has been done for an extensive period, nothing is happening, it's not settling, and then how do you now cover the wound? And I'm sure Dr. Vikram and you, Dr. Kaustav, also have a similar experience. So the reason why I like to change it every third or fourth day is if I'm only doing VAC alone, I would probably keep even for up to 5 days. The reason is that it's very simple. Why do we have a bath every day? We have a bath every day because there is always some accumulation of sweat, the excretion that happens with the sweat, environmental pollution, oil from the skin, etc. And you want to remove it all every day to keep it clean. Any wound surface, even if you're sucking things out continuously, there is a certain amount of effluent and wastage that accumulates there that doesn't go through the pores of the foam and get down into your little receptacle canteen. So in a situation like that, unless you cleanse the surface of the wound regularly enough, you will get granulation perhaps, but there will be infection which will be still present there. So I don't like to keep my back dressings for too long. I find that every time I take them off, earlier to save costs, I would do it 7 days, 8 days, thinking, Indian scenario, let's not follow the West. But I found that they would stink a lot. It would be far more difficult to prise the foam off. It would peel off my neogranulation. So in the long run, I've over time realized that probably 3-4 days is the right time to change the dressing. Right. That's at least my experience.
Agreed. Yeah, I think we have come out with a good discussion. So, Kaustubh, you would like to say for the next what are we doing on next week?
Yeah. So let us close down this lecture. So we will be meeting next Thursday 6 p.m. With Dr. Vikram will be presenting on various advantages, disadvantages, indications, and contraindications of skin grafting and various other modalities except the flaps. The flaps will be the next week. That will be a lecture taken by Dr. Ajinkya. So next Thursday 6 p.m. skin grafting.
All right. I think thank you very much. Thank you, Dr. Viraj, for joining, and thank you, Dr. Vikram. So we'll be signing off now and see you all next week.
Thank you. Stay safe, everyone.
Yeah. Stay safe.
Yeah.
Bye.